We'll conclude Chapter 10 by talking about Medicare. Now remember, Medicare is basically insurance for those who are elderly. So you are eligible for Medicare if you're over age 65 and you have worked and paid Medicare payroll taxes for 40 quarters. Don't ask me why they say 40 quarters instead of 10 years. I suppose because it allows you to patch together fractional years. But if you have been employed and paid 40 quarters of Medicare payroll taxes and you're over 65, you are eligible. Other ways you can achieve eligibility is to be unfortunately diagnosed with end-stage renal disease or Lou Gehrig's disease, and you have automatic eligibility right away with those diagnoses. Finally, you could have Social Security supplemental disability income. There is a 5-month waiting period before you get your first disability check, and then a 2-year waiting period between that first year disability check and the beginning of Medicare coverage. So you actually have to wait 29 months between your disability and when you get Medicare coverage. Medicare is paid through payroll taxes and then some enrollee premiums that we'll talk about. Let's look at the components of Medicare. The first component, Part A, covers inpatient hospital services. The vast majority of Part A is focused on inpatient care. It covers the hospital bill itself. It does not cover the surgeon that does the surgery while you're in the hospital. It just covers the inpatient hospital bills. It also covers post-hospital nursing home care and hospice care, but that's a small fraction of the total dollars spent. Part A, once you're eligible, you get it. No premium is required. You just are covered. Part B, on the other hand, isn't voluntary. You do have to pay a premium to enroll in Part B, and that covers the balance of medical services, physician, outpatient hospital, emergency department, things like that. Nearly all eligible people choose to enroll in Part B as soon as they're eligible, because if you delay and want coverage later, you have to pay this exorbitantly high premium the rest of your life. You never get the more moderate premium that the early enrollees get to take advantage of. Part C, sometimes called Medicare Advantage, actually replaces Part A and B. Some Medicare Advantages also replace the pharmacy coverage we're going to talk about in a minute in Part D. And Part A and B is replaced with private insurance. So basically, Medicare Advantage was established to incent people to leave traditional Medicare and go into managed Medicare and all of the benefits of managed coverage, managed health care. The premium and the cost sharing is set by the insurer, but those insurers also get payments directly from Medicare. So the premium payment that you make is more like the Part B premium payment. Part D coverage is relatively recent also. It is voluntary pharmacy coverage. Part D is delivered all through private insurers. There is no government-run Part D plan. Part D plans are often standalone. You have Part A and B through traditional Medicare, and you buy a standalone Part D coverage plan to fill in the pharmacy coverage. Alternatively, you could buy a Part C Medicare Advantage plan and buy a richer one of those plan options that includes pharmacy coverage. About 85% of eligible seniors choose to enroll in some form of Part D, either as a standalone plan or together with a Part C plan. Looking at it another way, in a table form here, you either have traditional Medicare or you have a Medicare Advantage plan. If you pick traditional Medicare, then you get Part A and enroll in Part B and can optionally also enroll in Part D if you want pharmacy coverage. Alternatively, you can choose a Medicare Advantage plan and get your inpatient hospital and your medical surgical coverage through Part C, and possibly picking a rich plan that includes the pharmacy coverage that is typically delivered through a standalone Part D plan. Now let's talk about cost sharing. This cost sharing is indexed, so it changes every year. I'm going to show you the 2016 cost sharing for traditional Part A. So this is your hospital benefits. There's no premium, as I mentioned earlier. The payment for an inpatient admission, and these are paid each admission, is in 2016, you have a deductible. So when you get admitted that first day, you pay $1,288. But then if your stay is less than 60 days, and the vast majority are, there's no other cost. If you're extremely sick and you have a long extended stay in ICU perhaps, and then transferring to general room, you start to pay, beginning with day 61, $322 per day, with the Part A paying the balance of the cost. Days 91 and beyond, it jumps to $644 for each lifetime reserve day. So each admission, you get a minimum of 90 days coverage. And then over the course of your lifetime, you have 60 lifetime reserve days, which can extend a hospital stay beyond day 90. Once you have used up all your lifetime reserve days, if you have another admission or continue in an extra long admission that goes past 150 days, you have to pay all the cost of the admission. Part B, the outpatient and physician services, there is a premium. In 2016, that premium is $104.90 per month if you make under $85,000. When we get to discussion of the Affordable Care Act, you'll learn that the Affordable Care Act caused premiums for Part B to be higher for those who make higher incomes. And so 2016 premiums range from $121.80 to $389.80 per month for the people who make more than $80,000. And of course that amount gets higher as your income goes up. There is cost sharing at point of service, so you pay those premiums, every month, but then if you go to see a doctor, there is cost sharing. There's an annual deductible, so at the beginning of the year, you pay the first $166. After that, you pay 20% of all remaining costs. There is no out-of-pocket limit. Part D is more complicated. The premium is set by a private insurer, because remember, Part D, there is no government plan. It's all private carriers. Again, you make more if you make more than $85,000, you pay a surcharge. So you would pay whatever that premium is that the private insurer is requiring, and then you pay an additional $12 to $72 depending on your income. Now, the plan design, the actual cost sharing at point of service for Part D plans, is pretty complex. I'm going to talk you through the minimum coverage. If you pick one of the richer plans, you may be paying a lot less than this. So this is the minimum amount of coverage that an insurer can offer. At most, there is a $360 annual deductible. So the first $360 worth of pharmacy benefits that you spend, you pay as a deductible. After that, you pay 25%. The plan pays 75% until all of the plan payments, those are ones made by you and made by the plan, both the deductible and that 25% cost sharing range, when all of those sum $3,310, then you hit the donut hole. Prior to ACA, once you hit the donut hole, the minimum coverage said you pay everything until you get to phase 4, the catastrophic phase. Now, ACO is closing the donut hole. It's called a donut hole because it's a hole in the middle of the coverage, like a hole in the donut's in the middle of the donut, right? You get this early coverage, then there's this hole, and then catastrophic kicks in. Doesn't make a lot of intuitive sense. It's really hard, conceptually confusing for the individuals, but what it did was it made it affordable. It gave catastrophic protection without costing the government too much because of that gap in coverage. All right, so ACA reforms, it's phasing out. So in 2016, instead of paying 100% of all the costs in the donut hole, the patient's paying 45% for brand name drugs and 58% for generic drugs. When total patient spending summed up over the first 3 phases hits $4,850, then you move to catastrophic coverage. In that catastrophic phase, you pay the greater of 5% of the drug cost or the copays that I have listed here, $295 for generic drugs, $470 for brand name drugs. And that's for a 30-day supply. Now, Medicare, the Centers for Medicare and Medicaid Services and their Medicare management, they've done some really interesting innovations in their efforts to control costs. They're always doing experiments and expanding out new programs, and often those programs are successful and adopted by private payers. We're going to go through some of those experiments that were successful and were adopted. So in 1983, they imposed something called the prospective payment system. Prior to PPS, Medicare reimbursed hospitals based on the cost of doing business. So you can see that that created an incentive for hospitals to inflate costs and add technology and provide really generous benefits because they knew all of their costs would be reimbursed. And growing to be a very large hospital is cool and has prestige. So, of course, hospitals got huge and charged Medicare lots of money. So what they did was they imposed the prospective payment system, which said, okay, instead of this cost-based reimbursement, we're going to go to a fixed fee per admission type. And that fee varies depending on the complexity of the admission. And that's going to encourage efficiency. And we did see dramatic reductions in lengths of stay because the hospitals had no incentive to let somebody dawdle around in the hospital. They needed that. As soon as the person was capable of being discharged, they need the bed for somebody else. And so there are a whole bunch of different admission types. Those admission types are categorized by something called the DRG. That stands for Diagnosis Related Group. So there's a DRG for vaginal deliveries of babies. There's a DRG for pneumonia. So each admission type has its own DRG code and the fee associated with that. There was a revision in 2008 that added severity distinctions. So instead of just having a generic pneumonia admission, you would have pneumonia without complicating conditions and pneumonia with complicating conditions. Maybe you get a staph infection or something like that. And so there's complications that you have to deal with. So you get a higher fee. Another reform in 1992 was the development of the resource-based relative value system, or called the RBRVS. This affected payment of physicians and the outpatient hospital facility costs. So it's based on the type of procedure. All of these are 5-digit codes. For example, 99213 is probably the most commonly used code in the book, other than the code for drawing a blood sample. This is an office visit for an established patient of moderate complexity. That is the standard 15-minute office visit when you already know the patient. That's very common. Vaginal delivery is another very common one, a very simple vaginal delivery where you didn't have to use forceps. That's 59409. What the RBRVS is, you see that name, it's a relative value system. So what it is a schedule of weights, essentially saying this procedure should cost twice as much as that procedure, and this other procedure should cost half as much. And they take that schedule of weights and multiply by a conversion factor to get a geographic specific fee. One of the philosophical motivations for developing the resource-based relative value system is the fact that primary care was undercompensated. Basically, you had to cut to get paid, is what they used to say. The surgeons, because they were cutting and they were doing these complex procedures, were getting really generous reimbursements. But the complex cognitive work that needed to be done to diagnose conditions in primary care setting, all of those cognitive tasks, which often people will come in with these vague symptoms and you have to do that diagnosis. It's not a slam dunk, but you're not cutting, you're doing it, it's all in your head. You can't see the procedure, and so those things tended to be undercompensated. So the philosophy was to try to shift those relative weights so that primary care got a more equitable reimbursement. Of course, that hasn't lasted over time. influential doctors get on the committees that review these and update them every year. And so over time, the primary care reimbursement rates relative to other things has sunk down again a little bit. And so there's a conversation about a new correction coming. And in fact, in the Affordable Care Act, there were some increased payments for primary care, particularly under Medicaid, in the first couple of years of the Affordable Care Act. There was an abortive attempt at volume controls. The Sustainable Growth Rate Program was established in 1997, and it was established to contain Part B costs. So we've got this fee-for-service reimbursement, but there was nothing controlling utilization. On the hospital side, the DRG system controlled length of stay, so that controlled utilization in a way. But on the physician side, there was nothing controlling utilization levels. And so the conversation said, well, all right, we're going to look at the total spending for Part B, and if it grows faster than the gross domestic product, then per procedure fees are going to be cut back. So if volume goes up, then we're going to cut the fees so that the growth in the total fees, the total spending doesn't exceed the gross domestic product growth. Well, it never really got implemented. There's been growth in technology, which forced growth above the gross domestic product and other things going on. So we just never hit the target. Congress would pass a little fix every year. So it never really went into effect. And the 2015 CHIP Reauthorization Act actually took that away. They just decided it didn't make sense. We're never going to implement it. And it's a controversy and wasting legislative time to do the annual fix. Let's get rid of it. And so they did. The Medicare Modernization Act of 2003 was a really important change. It added the Part D coverage, the pharmacy coverage, and it expanded access to private Medicare coverage through the establishment of Part C, that Medicare Advantage. Part D, we know after the passage of Part D, seniors are using dramatically a higher volume of prescription drugs. Of course they are. They can afford them now. And there's some evidence of substitution from non-pharmacy services to pharmacy services, for meaning that because the individual is taking their drug that maybe is a preventive drug, we're not seeing the need for care elsewhere. And so it is increasing efficiency in the delivery of care because you can now use pharmacy as one of the tools in your toolbox in delivering care. On the Part C side, Medicare Advantage, sometimes we just shorten that to MA. MA insurers are paid by the Centers for Medicare and Medicaid Services based on average area costs for traditional Medicare. So they look at the traditional Part A and Part B and they say, okay, on average, it's costing us $800 per month to cover an individual in Minnesota on traditional Medicare. Okay, Minnesota MA insurers, you get $800 a month to provide this. And then the MA insurers will then collect any supplemental payments they need to. Typically, because they tend to attract a healthier group, actual expenses tend to come in below those payment rates if they were just delivering traditional services. 75% of that difference is kept by the plan, and they're required to use that to provide additional benefits, perhaps reduced copays. So we might fill in that 20% coinsurance. Remember, under Part B, there's a small deductible, but then 20% coinsurance with no out-of-pocket limit. So the MA insurer may say, oh, it's 20% up to $3,000, and then the plan pays the balance. So that 75% helps fund improvements in benefits. Let's talk about market power. What happens with these changes? The Medicare Advantage, Part C, was supposed to establish a private Medicare market, encourage managed care and more efficient delivery of care because it allowed private carriers to innovate in the delivery of care to elderly population. But we've got that 75% of savings requirement that I just talked about. So if I'm attracting a healthy group, chances are I'm going to have savings. So I'm going to have the 75% of that in a pot of money that I have to use to expand benefits. But I may use that money up pretty quickly in filling in copays, and then I got to start to add peripheral benefits like perhaps transportation services to my appointments or vision care or things that the consumers may not value as much as it costs to provide. They could be peripheral stuff that consumers don't care about. And so that 75% requirement actually may cause some inefficiencies. We talked about the fact that MA plans typically get favorable selection. They are managed care, typically a restricted provider network. You get in-network benefits and out-of-network benefits. And because of that, it's the healthier people who tend to want to take that network restriction. And so MA plans typically get a healthier group relative to traditional Medicare, but the payment is based on the average cost of traditional Medicare, so which is the sicker population. So we're probably overpaying insurers. And in fact, when we talk about the Affordable Care Act, you'll hear that there's one of the things that they did is an adjustment for that. So they're going to start phasing out, reducing the payments to MA plans and not have them be as high as traditional Medicare. So you can see that there are some market inefficiencies because of watching where MA plans establish themselves. They tend to establish themselves where traditional Medicare costs are high, so there's greater potential for that overpayment, like Florida. I'm sorry, I have a typo there. Like Florida, because in Florida, traditional Medicare reimbursements are really high, so the MA plans can come in and create really rich, attractive benefits. When the MA market has a high HHI, remember that Herfindahl index that measures concentration. So another way of saying that is when the market's concentrated and there are very few insurers, we see fewer plan options, fewer additional benefits, higher copayments. So we see less efficiency when there's less competition. So there are some market power elements happening in the Part A market. Similarly, in the Part D market, because there's no government run option and it's all private plans, we've got to think about market power and what's going on in the markets here. There could be more than 30 plans to pick from in an area, so the market can get pretty confusing, especially with this weird donut hole and some plans filling in the donut hole and some plans not filling in the donut hole. It can get really confusing. Remember that insurers who provide Part D plans, they're not geographically bounded. They don't have to negotiate individual networks in provider networks everywhere they provide benefits. They can go to the big national players like Walmart and Walgreens and Target and negotiate a pharmacy network with them, and then they've got national coverage. So Part D providers tend to be there tends to be a national oligopoly with competitive fringe because of the lack of geographic boundaries. This complexity of the phases and the donut holes, of course, makes comparing plans difficult, and we find that patients are very price elastic, so they are really sensitive to the pricing of Part D plans. Remember, pharmacy may be a standalone plan, usually paired with traditional Medicare or incorporated into a Part C or Medicare Advantage plan. One thing we haven't talked about much is formularies. Formularies are the list of drugs that get preferred status. They get covered with a lower copayment. So you might have generic drugs, you might then have the next label be brand drugs that are on the formulary and then brand drugs that are not on the formulary. And that latter class could either have a really high copayment or they may not be covered at all. Well, in private insurance, within a therapeutic class, like one particular kind of lipid-lowering drug, you might have only one brand name on the formulary. Medicare requires that if there are two products in that therapeutic class, that there have to be at least two products on the formulary. So those formularies are not as tight as non-Medicare drug plans. Let's wrap up Chapter 10 by summarizing the ACA changes that affect both Medicare and Medicaid. Remember, the Medicaid excuse me, I misspoke. The Medicare Advantage plans payments will be reduced over time to reflect that favorable selection. The fact that they are getting a healthier population than traditional Medicare. So rather than basing their reimbursement on the cost of traditional Medicare in the area, it's going to be reduced over the traditional total cost. We also talked about the addition of income-based premiums for Part B and D. Remember, if you make over $85,000, you had to pay some supplementary premiums for those two coverages. Provider payment reform. We've talked about shared savings and bundled payments over and over again, and there were pilot experiments about using those that were funded and established through ACA, and those have been going on. Some of them started right away in 2010 and 2011 after the passage of the act. There's been an increase in primary care reimbursements. That's the adjustment of the RBRVS that I talked about because it had gotten out of whack, and the primary care relativities were below where they should be, and so those were brought back up in line with where they should be relative to specialists. There's the phase out of the Part D donut hole that we talked about. We're partway there, about halfway there, because the folks are paying about half the cost in the donut hole instead of 100% of the cost. We talked about the payroll tax for Medicare being increased for the wealthy. And in fact, that payroll tax is not just a tax on earned income, but the wealthy, when they do their annual income tax report, when you file your taxes, they actually look at investment income and tax that to help pay for Medicare as well. The Medicaid expansion to adults without children is one of the biggest pieces of ACA expansion. Of course, the Supreme Court decision in 2012 made that voluntary by state. And then finally, a concept we haven't really talked about much is the disproportionate share payments. What these were payments by the government to hospitals in geographies that had a disproportionate share of poverty. It was to help those hospitals finance charity care. Well, because we had the Medicaid expansion, theoretically hospitals weren't going to need that anymore. So there was a reduction in disproportionate share payments, and that helped pay for some of the costs of the ACA expansions. But the problem is not all of the states expanded Medicaid, and so states like Texas and other states that did not expand Medicaid, those hospitals are losing their charity care support, but they're not getting the Medicaid coming in to help them out. So actually it'll be interesting to watch over the next few years. Those hospitals they do have a lot of political clout, and they may start pressuring their governors and their legislators to consider adopting the Medicaid expansion because they are getting caught between a rock and a hard place. And that wraps up Chapter 10.